Hello.
Good morning, sir.
Hello.
Yes, sir. Good morning.
Good morning.
Sir, I have called Destina. There is some network issue. They'll log in soon, sir.
Okay, whenever they log in, they can start. It's just 2 minutes. So whenever they log in.
Okay, sir. Sure.
ये तो अगर अब कर लोगे क्या नहीं वो लिंक कहाँ है नहीं वो खुल गया
मैडम लॉक अंदर से लॉक करो
हाँ म्यूट कर
recording.
Hello, Tehsina. Have you joined? Are you ready to start?
Good morning, sir.
Good morning, Tehsina.
Morning.
Who's this?
Sir Zeba. Good morning, sir.
Zeba. Good morning. Yeah, please start.
Good morning, all of you. Welcome to
Yeah.
the virtual round presentation. I'm Dr. Zeba. Along with the Dr. Tessin and Dr. Dimanji, will be presenting this seminar. Today's topic is the metastatic carcinoma of the lung. So let's get started with the first case. This is a 52 years old gentleman, resident of the Maharashtra, laborer right-handed, present with the violent.
Hello, Zeba. Your screen is being shared correctly. I have a doubt. Is it come?
Yeah, you have not shared the PPT. It is just your email, the mailbox.
So just a minute.
Tehsina,
Yes, sir. Just a minute.
that's why you are presenting, Zeba. Okay. So, okay. Anyway, you all are transition. JR1s will become JR2s. JR2s will become JR3s. JR3s will become SRs. So,
So just a minute. So is it visible now?
it's not the PPT. You have not opened it.
So we
Or is there that lag, time lag? That's why we are not. Anuj, please guide them. Huh?
Yes, sir.
It is showing. So Dr. we opened the presentation on that.
No, but this is not showing up. Only that the PPTs are mentioned. Only that is opening up session. Can you minimize this and just see that the screen sharing is correct? Where are you?
Yes, we are on 10th floor.
Where are you presenting from?
10th floor.
Huh?
10th floor.
10th floor. Okay. Yeah, now it is visible. Just make it full screen and you can start. Yeah, it's fine now. You can, yeah.
So this is a 52 years old gentleman, resident of the Maharashtra, laborer, right-handed, present with the headache in the bilateral parietal region. For 1 month, he is also having a chief complaint of difficulty in speech and blurring of the vision in the right eye for 2 weeks, associated with the dry cough, exertional dyspnea for 15 days, with the low backache since 1 week. Sorry. Patient was apparently all right 1 month back, then he developed the headache in the bilateral parietal region. It was associated with the difficulty in speaking, blurring of vision since 2 weeks. There is no history of the vomiting and seizure. He's also had the chief complaint of the dry cough, exertional dyspnea since 15 days, not associated with the fever or blood tinged sputum. Then he developed the low backache since 1 week, which was increased during the stooping movements and relieved with the medication, was affecting the sleep and the ADL and not associated with the bowel and the bladder abnormality. There is no history of the difficulty in breathing at rest, no history of the change or hoarseness of the voice, hemoptysis and the chest wall pain. No history of the similar complaint in the past, no history of the pulmonary TB, any hospital admission, any surgery, and any episode of the shortness of the breath. He's a chronic smoker, 20 packs years. He takes the mixed diet, sleep is adequate, normal bladder and bowel habits, no drug allergy, no family history of the malignancy. He belongs to the lower middle socioeconomic class. He lives in the Pakka house with the inbuilt sanitation with the municipal corporation water. Patient was explained about the examination procedure and examined in a sitting position in under full privacy after taking the verbal consent. Thin build and malnourished. He is conscious, alert, well oriented to time, place, and person. GC is good. KPS is 70. Wheelchair bound. Effort tolerance to first floor. BMI is 19.6. BP, heart rate, and respiratory rate are normal. On general examination, there is no pallor, clubbing, edema, icterus cyanosis, no pedal edema. There is a single left supraclavicular lymph node palpable, which is non-mobile, hard, non-tender, 2 by 2 centimeter in size. On inspection, chest wall is symmetric, normal resonance present. On auscultation, decrease the breath sound on the right side. Heart rate is normal, no abnormal heart sounds. Abdomen is soft and non-tender. On neurological examination, he is conscious, alert, well oriented to time, place, and person. Power in both the limbs are 5 by 5. No cerebellar sign, no cranial nerve deficit. Gait is normal, speech is slurred, and no bowel and bladder deficit. On local examination, pain score is 8 by 10 without analgesic. Tenderness is present in the lumbar spine at L5 region in the bilateral sacral area. CT image is showing the 6.1 into 5.5 into 5.9 centimeter lesion in the superior mediastinum, encasing the arch and descending aorta, left common carotid artery, and the left subclavian artery. Posteriorly, it infiltrates the prevertebral space with the erosion of the D1 and D2 vertebral body. Corresponding the neural foramina and the costovertebral joint, there is an epidural intraspinal extension, likely cord compression. Diffuse centrilobular emphysematous changes are seen in both the lungs. Patchy area of the consolidation with the multiple periregional centrilobular nodules are seen in the right upper lobe, and the multiple enlarged nodes are seen in the right hilar region, which is 2.9 into 1.8 centimeter. This is CT image which is showing the mediastinum mass and the periregional nodules are seen in the right lobe. This is again the CT image of the abdominal window, which is showing the mass in the superior mediastinum, and this is a multiple periregional nodes are seen. And here, this is a mediastinum mass which infiltrating the D1 vertebra. On PET image, it is showing the right upper lobe lesion with a multiple enlarged node in the right hilar region, multiple metastatic small nodules in the bilateral lung parenchyma. Low-grade hypermetabolic multiple lesions are seen in the bilateral frontal parietal region of the brain. Multiple liver mets are present. Multiple metastatic bilateral neck and mediastinal hilar nodes are present. Bilateral adrenal mets are present, and the multiple lesion in the C2, C7, D1, L5, bilateral sacral area, bilateral iliac ischium pubis, intertrochanteric region, and the bilateral femurs. MRI brain is showing the multiple enhancing lesion in the bilateral cerebral and the cerebellum hemisphere. Periregional edema is seen, no evidence of the intracranial hemorrhage. And this is a MRI. This is a brain image which is showing the multiple mets, parenchymal mets. Here we can see the multiple parenchymal mets. He underwent the CT-guided biopsy, supraclavicular lymph node, which is showing the non-small cell lung cancer, adenocarcinoma. TTF1 is negative, EGFR is positive, and rest of the driver mutation are negative. Routine blood investigation is done. PFT is showing the mild obstruction and restriction without the bronchodilator reversibility. FEV1 to FVC ratio is 0.78. FEV1 is 70.9%, FVC is 73.2%, and DLCO is 76%. 2D echo is normal. So final diagnosis will be the 54 years old gentleman, no comorbidities with the metastatic adenocarcinoma of the right upper lobe, CT4, N3, M1C, mets to the brain, bone, liver, and adrenal. So treatment is planned for the chemotherapy, pemetrexed and carboplatin. He received one cycle of the pemetrexed and carboplatin, started on the tablet gefitinib. Plan was Palati to the primary 20 gray 5 fraction and WBRT to 20 gray 5 fraction, and Palati to L5 and bilateral sacroiliac joint to 8 gray single fraction. RT planning is done. A patient was simulated in supine position with the arms above head. Fiducials are placed at the Ziegfeld sternum. 5 mm NCCT curse is taken for WBRT. Clinical marking is done. Bilateral sacroiliac joint, lumbar vertebra treated clinically. The patient was treated using the APPA portal, and the picture is showing the 95% of the dose color wash covering the whole PTV. Now coming to the second case, 66-year-old postmenopausal lady, resident of the Andheri, present with the complaint of the intermittent productive cough since 2020 with a recurrent episode. She also having a complaint of the sharp pain over the left iliac region since 15 days. Patient was apparently all right 3 months back. Then she developed the intermittent episode of the productive cough, whitish sputum, non-blood stain, less than 1 cup per day, sharp pain over the left iliac region, which was radiating to the left hip since 15 days. Pain is increased on movement, relief with the hot compression, not associated with the bowel and the bladder complaints. No history of the change or hoarseness of the voice, hemoptysis, chest wall pain, fever, no history of the weight loss, night sweats, no history of the difficulty in breathing at rest or exertion, no history of the nausea, vomiting, headache, and seizures. No history of the similar complaint in the past, no history of the pulmonary TB, any hospital admission, and any surgery. Denies any addiction, no history of the passive smoking. She is a hypertensive, diabetic, and hypothyroidism, which is controlled on the medication. She takes mixed diet, sleep is adequate, no drug allergy, no family history of the malignancy. She belongs to the lower middle socioeconomic class, lives in the Pakka house with the municipal corporation water facility. She is a para 2 L2, postmenopausal since 15 years. For general examination, patient was explained about the examination procedure and examined in a sitting position under the full privacy after taking the verbal consent. Moderately built and nourished. She is conscious, alert, well oriented to time, place, and person. GC is good. KPS is 80, and effort tolerance is up to the second floor. BMI is 20.57, and BP, heart rate, and respiratory rates are normal. On general examination, findings are no pallor, clubbing, edema, icterus, and cyanosis. No lymph node is palpable, no pedal edema. On systemic examination, chest wall is symmetric, equal expansion bilaterally, normal resonance, equal sounds are present bilaterally. Normal heart rate, no abnormal heart sounds are present. Per abdomen is soft and non-tender. On local examination, pain score is 4/10 after analgesic, and without analgesic is 7/10. Bony tenderness is present at the left iliac. CCT is showing the heterogeneous enhancing lesion in the anterior segment of the right upper lobe, which encasing the right pulmonary artery, enhancing pretracheal and the precarinal adenopathy, which is 1.8 into 1.3 centimeter. Medially, it invade the mediastinum. This is image which is showing the mass in the mediastinum, and there is a mass in the mediastinum, and there is a hilar node is present. PET-CT is showing the progressive decrease in the mass, and there is a uptake is increase in the left iliac bone. MRI brain is showing the no evidence of the brain metastasis. This is the image which is showing the lytic lesion in the left iliac bone. On PFT, it is showing the mild obstruction and restriction without the bronchodilator reversibility. DLCO is 76%, FVC is 73.2%, FE1 is 70.9%, 2D-ECO is normal. On biopsy, it is showing the adenocarcinoma. TTF1 is focally and weakly positive. EGFR is negative, and other driver mutations are also negative. So final diagnosis is the 61-year-old postmenopausal lady with the oligometastatic adenocarcinoma of the right lung with a single met to the left iliac bone. Staging is T4N2M1B. She was planned for the 6th cycle of the pemetrexed and cisplatin, which was taken outside. After the 6th cycle of the chemo, the PET is showing the right upper lung primary, which is showing the significant reduction and increase in the metabolic activity of the left iliac region. She was kept on the observation. On the further PET-CT image, there is a reduction in the primary lesion and increase in the metabolic activity of the left iliac bone. Here we can see the uptake in the right hilar lesion, and this is a lytic lesion in the left iliac bone. She was planned for the SBRT to the right lung lesion to a dose of the 50 grade 10 fraction, and the left iliac bone to a dose of the 30 grade 5 fraction. Patient was simulated in the supine position, arms overhead, wedlock is used, no knee rest is used. No knee rest, fiducials at the Xiphus sternum and pubic symphysis, and 2.5 mm NCCT curves is taken from the L3 to mid-thigh. For 4D CT, simulation was done in supine position, arms overhead, wedlock is used, and 4D CT scan is taken for the lung lesion, 2.5 mm CCT curves is taken. These are the phase errors. Here we can see the contouring of the GTV in the MIP, which is copied to the free breathing scan to generate and compare the ITV. Here, this is a contouring image in the free breathing scan. This is a GTV, ITV, and this one is showing the PTV. This is a 100%. This is 100% covering the color wash image is showing the 100% coverage of the GTV. This is a 95% coverage of the PTV, and this one is the 50% of the spillage. This dose volume histogram is showing that 95% of the dose which is received by the 98% volume of the PTV. Here we can see the contouring of the left iliac bone lesion, which is, this is GTV and this is PTV. This one is the 100% dose, 100% dose covering the PTV. This one is showing the 95% of the dose which is covering the PTV. And this one is the 50% of the spillage. And this dose volume histogram is showing 95% of the dose which is received by the 99% of the volume of the PTV. And this one is for the lumbosacral plexus. So the rest of the part will be presented by the Dr. Jensen. Yes.
The AGCC subdivides the M category in non-small cell lung cancer into M1A, B, and C. M1A is defined as disease in the contralateral pulmonary nodules or malignant pleural or pericardial effusion or nodules. M1B is defined as a single extrathoracic metastasis in a single organ, including a single non-regional node, whereas M1C is multiple extrathoracic mets in a single organ or multiple organs. The NCCN guidelines for the management of stage 4 lung cancer includes pre-treatment evaluation with an FDG PET-CT scan, MRI brain, and molecular testing, and offering either local therapy or systemic therapy accordingly to the patients. The management includes a detailed history, complete physical examination, investigations such as FDG PET, brain MRI or diagnostic CT of chest and upper abdomen, biopsy, blood tests, pulmonary function test, and other supportive care. The goals of therapy in metastatic lung cancer are to improve the quality of life, to prolong survival. Patients who are symptomatic require prompt intervention. A wait and watch approach is generally not recommended. Systemic therapy is indicated in metastatic disease. Palliative treatment such as palliative RT is used to treat the localized symptoms. Conditions such as CNS disease, cord compression, or painful bone mets are special conditions where local therapy can be administered prior to the systemic therapy. So a patient of stage 4 non-small cell lung cancer has to undergo immuno and molecular testing. If there are no targetable mutation identified, then if the patient has a PD-L1 expression in more than equal to 50% of the cells, he can be treated with pembrolizumab, carboplatin, pemetrexed plus pembrolizumab. If the PD-L1 expression is less than 50% and it is non-squamous histology, a patient can be offered platinum doublet plus minus bevacizumab, carboplatin, pemetrexed plus pembrolizumab. If the PD-L1 expression is less than 50%, but it is squamous histology, patients are treated with platinum doublet. In cases of patients where identifiable driver mutations are driver mutations are identified, they are treated accordingly to appropriate TKIs. So if no driver mutations are seen, tumors can be treated, tumors with more than 50% PD-L1 expression can be treated with upfront immunotherapy, otherwise platinum doublet therapy is used. So driver mutations are alteration of genes which are important for tumor maintenance. They are present in around 25 to 30% of non-small cell lung cancer. Targeted therapy is that treatment that uses drugs to target specific genes and proteins which is involved in growth and survival of cancer cells. Some of the common driver mutations which are seen in non-small cell lung cancer are EGFR, which is seen in 10 to 30% of the patients. This is diagnosed with the help of PCR. It is most commonly seen in women, non-smokers, or those who have a less Pacquiao history, Asians, and acnocarcinoma. The most common mutations are exon 19 deletion, exon 21, 18, and 20 mutation. So the various TKIs which are available for EGFR positive patients are gefitinib, erlotinib, and ecotinib, which are the first generation TKI. Second generation is afatinib, and third generation is osimertinib. 50 to 80% of the patients develop resistance after a period of 11 months after to first or second line TKI. The T790M mutation is the most common mutation which confers resistance. It has been seen that around 30% of the treatment naive patients have the T790M mutation. The other mutation which is seen in non-small cell lung cancer is the ALK, which is seen in 10 to 15% of patients. It is identified with the help of FISH or IHC. It is more commonly seen in adenocarcinoma, young patients, light or never smokers. ALK positive tumors usually show resistance to EGFR TKIs. The TKIs which are available for ALK mutations are crizotinib, which is the first generation. Second generation is seritinib and alectinib, which is active in CNS disease. Patients usually develop resistance within 1 to 2 years of therapy. The third generation TKI is lorlatinib. ALK positive patients benefit from multiple sequential ALK TKI. There have been multiple randomized controlled trials which have shown the benefit of using a TKI over chemotherapy in patients who have a driver mutation. So this is the UATAC trial which compared erlotinib versus platinum-based chemo. And it showed a PFS and OS benefit with the use of erlotinib in comparison to chemotherapy. This is the FLORA trial which compared osimertinib versus gefitinib and erlotinib. And it showed that the use of osimertinib as the first-line TKI in treatment-naive patients was associated with a better median PFS and OS. We also have a study from TMH which compared gefitinib versus gefitinib and pemetrexed and carboplatin, where it was found that gefitinib in combination with chemotherapy had better PFS. The other mutations which are seen in non-small cell lung cancer are ROS1 fusion, MET, BRAF, and RET mutations. Coming to immunotherapy, so this is the Keynote 024 trial, which was an international randomized phase 3 trial which compared pembrolizumab monotherapy versus platinum-based chemotherapy in patients with untreated stage 4 non-small cell lung cancer who had a PD-L1 tumor proportion score of 50% or greater. So they concluded that the first-line pembrolizumab monotherapy had better PFS and OS benefit over chemotherapy, had better response rates, and also had lesser treatment-related adverse effects. For coming to the NCCN recommendations for chemotherapy, if the patient has a good performance score and no contraindications to PD-1 or PD-L1 inhibitors, the preferred regimen includes pembrolizumab, carboplatin or cisplatin, and pemetrexed. In case of contraindications to PD-1 or PD-L1 inhibitors, bevacizumab, carboplatin, paclitaxel, or bevacizumab, cisplatin, paclitaxel, or bevacizumab in combination with carboplatin and pemetrexed can be offered to patients. The indications of RT in metastatic non-small cell lung cancer are in palliative RT, oligometastatic disease, and as immunomodulation. So palliative RT can be offered to the primary disease and also to the metastatic sites such as the bone, brain, etc. So thoracic radiotherapy with palliative intent is used to relieve the tumor-related symptoms and to improve the quality of life. Doses of RT range from 10 gray single fraction to 60 gray in 30 fraction. There is no strong evidence that any regimen gives greater palliation. However, it has been seen that higher dose radiation treatment fractionation are associated with increased side effects, and the various shorter fractionation regimens like 20 gray in 5 fractions or 17 gray in 2 fractions provide good symptomatic relief. Palliative RT can also be offered to sites of bony metastasis. So in patients who have a bony metastasis without pathological fracture or structural weakness can be treated with short course radiotherapy. In case of a pathological fracture or focal lytic lesion, surgical fixation followed by radiation therapy can be offered. Some patients also present with epidural spinal cord compression. In such patients, if the symptoms are caused by direct tumor compression, then either surgery or RT can be offered to the patient. When RT is offered as a primary treatment, it provides reasonable palliation of pain. However, it is unlikely to restore the ambulation or reverse the neurologic compromise. There are a number of different fractionation regimens which include 8 gray in single fraction, 20 gray in 5 fraction, or 30 gray in 10 fraction. And it has been found that there is no difference in pain control or ambulation between them. There was an IAEA randomized trial which tried to investigate the optimal single-dose radiotherapy in the treatment of painful bone metastasis. Here, they randomized patients to receive either 4 gray in single fraction or 8 gray in single fraction, and they concluded that 8 gray in single fraction was superior in terms of pain relief at 4 weeks. So the other management options for bone metastasis include bone modifying agents such as bisphosphonates, which include zoledronic acid, alendronate, and denosumab. So bisphosphonates are usually given at the dose of 4 milligram IV every 28 days when the patient has a normal renal function. The prerequisite for administering bisphosphonates is dental evaluation. Denosumab is a monoclonal antibody against the rank ligand. It is given subcutaneously. It has been seen that denosumab is superior to zoledronic acid in delaying skeletal related events. So for brain metastasis, the various options include whole brain RT, radiosurgery, or surgery. So whole brain RT is the gold standard and the most common modality of treatment used. The regimens vary from 30 gray in 10 fractions to 20 gray in 5 fractions. There have been multiple randomized controlled trials in the past which has found no significant difference between the two. The side effects of whole brain radiation include somnolence, nausea, vomiting, dermatitis, and alopecia. This was the QUARTZ trial where patients with non-small cell lung cancer with brain metastasis were randomized to receive either optimal supportive care, which included dexamethasone plus WBRT, or optimal supportive care alone. The primary outcome was improvement of at least 7 quality adjusted life years. So it was found that the difference between the mean quality adjusted life years in both the arms was 4.7, and a trend towards better overall survival favoring the whole brain RT arm was seen in patients who were less than 60 years of age, who had a good performance score, who had no extracranial metastasis, who had a controlled primary, who had more than 5 metastases and had a higher GPA. Radiosurgery can be provided to patients who have metastases which are small in size, have a controlled extracranial disease, and have an excellent KPS. It may be frame or frameless SRS. The doses used for SRS vary according to the size of the metastatic lesion. So this was a study by Brown et al. Which investigated the role of adjuvant whole brain RT in patients who had 1 to 3 brain mets which were treated with SRS. And they concluded that SRS alone could be offered to such patients. Coming to the surgical option for the treatment of brain metastasis, it can be used in patients who have a single brain met. It provides immediate relief when patients have symptomatic mass effect. There are few studies from Patchell et al. Which has seen that surgery followed by observation versus surgery followed by WRT in patients with single metastasis were seen, and it was found that significantly higher recurrence rate was seen on the observation arm. However, there was no OS difference between the two arms. In another study, patients were randomized between surgery followed by whole brain RT versus whole brain RT alone, and it was seen that surgery followed by whole brain RT had a better median OS and functional independence as compared to WBRT alone. Coming to the concept of oligometastatic disease, so there have been various definitions in the past. Hellman and Weisselbaum in 1995 described it as a limited number of clinically detectable metastatic tumors The extent of disease exists in a transitional state between localized and widespread systemic disease. Oligometastatic disease represents intermediate state between locoregionally confined cancer and widespread metastasis, whereby the number of metastases in organs are limited. It typically ranges between 1 to 5 lesions. Further, oligometastatic disease can be defined as synchronous or metachronous. There are some other definitions such as oligoprogression, oligorecurrence, and oligopersistence. So there is this trial by Gomez et al., which was a multi-center randomized controlled trial, which randomized patients with stage 4 non-small cell lung cancer, which had 3 or fewer metastatic disease after first-line systemic therapy. They randomly assigned the patients to either receive local consolidative therapy, which could be in the form of chemoradiotherapy, surgery of all the lesions with or without maintenance treatment, or to receive maintenance treatment alone. So they found that the median PFS of patients who received the local consolidative therapy was much better as compared to patients who received maintenance therapy alone. Coming to the immunomodulatory effect of radiation. So when radiation therapy is used in conjunction with immunomodulatory agents, it triggers an anti-tumor immune response, which leads to higher treatment response and improved patient survival. So this was seen in the secondary analysis of Keynote 001, where there was a PFS and OS benefit with pembrolizumab in patients who had received radiation therapy.
Sorry, can't hear you.
So this was it for the presentation, sir. I had
Okay.
slides, but it was
Okay,
a bit
so
long.
it is all done. Okay,
Yes,
okay, just got over. So I think first you couldn't connect initially, isn't it, Tessina?
Yes,
Was
sir.
it planned this way that Zeba will present the initial the cases and then you will present, or because of that you all
No, sir,
changed?
because there were quite a few slides, so I'd asked her to present the case history initially.
Anyway, Zeba, have you had your thoracic posting or not?
Yes, sir.
You have had. Okay. Anyway, you presented quite
I'm in
well. You are in thoracic. Good, good. Otherwise, they would have been cross with you. So you presented well. So I think now, Tessina, you would answer the question. So your first case was, you summarize your first case. It was a middle-aged man
Yes,
with advanced metastatic non-small cell lung cancer with a driver mutation. Is that correct?
PFR positive.
And
Yes.
the site of metastasis were bone, brain,
Yes, sir. Liver.
bone, brain, and liver. Okay.
Yes,
so it is widely disseminated disease.
Yes, sir.
Okay. So what is the mainstay of treatment in such patients? So widely disseminated disease with a driver mutation, and the metastatic disease is symptomatic. The bone mets were symptomatic. Were the brain mets also symptomatic? Or
Yes, sir.
okay. So what is, if you summarize the treatment approach for such patients?
So because he has a driver mutation, so
No, in general,
yes, sir.
In general, I'm asking.
So for disseminated disease, the patients are treated with systemic therapy. In case there is a driver mutation present, then they can be started with the appropriate TKIs, or else chemotherapy can be offered to the patient in addition to immunotherapy such as pembrolizumab or nivolumab. And for treating the symptomatic sites, so we can offer palliative radiation therapy to those sites.
Okay, that's correct. So I think in that, and palliative radiotherapy, would you be very prescriptive? You should treat this way only, or you have to individualize?
So we can individualize.
I think that's very important. So in palliative treatment, it always has to be individualized depending upon patients, performance status, the symptoms, the extent of disease, the logistics, the expected acute effects, late effects, we do not bother so much. So all these things you have to take into account. So in that patient, if suppose someone said, no, I want to do some people are doing SBRT or
Yes, sir.
SRS for 15 brain mets, 12 brain mets, 9 brain mets.
Yes.
How would you argue against it?
So to offer SRS to a patient, so we have to take a lot of other factors into consideration, like the performance status of the patient, the disease status of the primary. So in this patient, sir, his performance status was not very good. He was wheelchair bound. His KPS was around 70, and the primary disease was not controlled. It was a large primary which was actually infiltrating the vertebra and causing cord compression.
Fair enough. And he has not just primary, he has a widely disseminated
Yes, sir.
disease. All
Yes.
organs are involved.
Yes, sir.
So what kind of symptom relief do you expect with palliative radiotherapy to the primary site? And normally, what are the symptoms for which you give thoracic radiation in such cases? In advanced or metastatic lung cancers, what are the symptoms which you expect to relieve?
So when the patient has worsening dyspnea or the patient has hemoptysis, so in this patient, because there was the chance of impending cord compression, so he had to be
because of the
treated.
intraspinal extension.
Yes, sir. Yes, sir.
Okay. And brain mets, I think one of you mentioned, I think for this case only, that you treat, it's not wait and watch. So how would you defend that? You say when the brain mets become symptomatic, you can treat that. Zeba, you mentioned that. For this case or was the other case?
Yes. So for asymptomatic patients with brain mets who have a driver mutation, sir, so the option of treating the patient upfront when the patient is asymptomatic is being investigated right now. So there are a couple of studies which are going on,
Good.
one in our own institute.
Good. So Anil or Naveen, would you like to add anything for the first case? Any question or thing they have not covered well?
No, sir, they have covered but quite well. Actually, the presentation and the presentation skills were very good. One question that I had was, we routinely don't do the pulmonary function test in patients of metastatic non-small cell lung cancer. Any particular reason why we have done that?
So in the second patient, prior to the SBRT,
No, the first
patient.
The first patient. No, you don't remember.
No,
I also
sir.
noticed. See,
Yes,
any
sir.
investigation? So now you answer this. Why we don't do pulmonary function test in metastatic, widely disseminated lung cancer? Why we don't do?
So because we will not be treating the patient with a radical intent, or normally we do. So normally,
so it will not affect the person's management.
Yes,
okay?
sir. Yes, sir.
So sometimes you might do that, but it will not alter the management. So that's
Yes.
why. Okay. So about the second case. So the second patient, to summarize, she was a lady without a driver mutation, adenocarcinoma lung without a driver mutation. It was T4A, N2 and M1B. Is that correct?
Yes.
M1B by virtue of solid bone metastasis,
Yes,
which
sir.
was symptomatic.
Yes, sir.
Okay. So the SBRT was done for both primary as well as metastatic site?
Yes, sir.
Okay. If suppose this lady had a driver mutation, would that have altered your management approach for this patient?
So we could have started her on the TKI, but since the lady was already symptomatic, sir, could have offered SBRT to the so both the lesion. The primary was a small lesion.
Okay, primary was small lesion. It was relatively.
Small, yes, relatively small, sir.
Yeah, by definition. So Anil, your thing about this patient, you like to comment?
Yes, sir. Even in case of the driver mutation positive, even if you have a small primary with regional node and 1 or 2 metastatic sites, it is advisable and recommended to proceed with the systemic therapy first, and then to plan for consolidation RT. The only reason is that so whenever we are treating with the first generation or the second generation TKI, the median progression-free survival has actually improved as compared to systemic therapy, but it's still below 12 months. So there are there are approximately 25 to 30% of the patient which will have the EGFR resistance in the first 3 months. So it is better to have the TKI for first 2 or 3 months, then response assessment, and if they believe and if they declare themselves as the oligometastatic state, then you can consider for consolidative local therapy.
Okay, sir.
And now Tesina, answer my question. If suppose the patient is very reluctant for a CT guided biopsy, okay, and or some other contraindication, surgeon feels that I can't do or not getting dates, whatever. Is there any other way through which you can try to discern the disease and its the nature of disease in terms of biological subtype or driver mutation? Just an FNAC has been done. FNAC has confirmed, they see that it is adenocarcinoma and patient doesn't want biopsy. Are there any other ways which are evolving for evaluation of patients with lung cancer and some other solid tumors?
Sir, bronchoscopy guided biopsy.
Bronchoscopy guided biopsy, yes. What other? So when you can't do an invasive biopsy, what are the other kinds of biopsies? I'm just sort of
Sir,
digressing.
NGS, sir. So next generation sequencing can be.
NGS is a way of looking at genes, but what? NGS on what?
Sir, liquid biopsy.
Liquid biopsy. So what is a liquid biopsy?
Sir, in liquid biopsy, sir, we look for some tumor cells in the blood specimen. So it's just take the blood sample and do not do any other invasive procedure.
Okay. So liquid biopsy. So I think in years to come, maybe in 5 or 10 years, maybe for lung cancer and some other cancers which have high rates of dissemination, a lot of these interventional radiologist guided or image guided biopsies, not in all patients, but in some patients they would not be required. And you said resistance. Do you know about the mechanism of resistance? You mentioned about resistance to TKI.
So yes, sir, for EGFR, so one of the most common methods of gaining resistance is the T790M mutation.
Okay. So now tell me the toxicities of TKI, a new TKI. Okay. So what are the toxicities? And one toxicity you have to mention, which is important.
For EGFR TKIs, sir, dermatitis and skin rash is very commonly seen, which can be in the form of pruritus and
okay.
Yes, sir. So patients can also develop mucositis, diarrhea. Then, so some of the TKIs also develop. So nausea, vomiting is there. So some TKI patients with TKI also develop. Arthralgia, malaise.
See, what I'm trying to ask is, so I'm talking of the latest generation TKI, something which has been just shown, pronounced in ASCO last year. So one of the, we don't call it toxicity, but actually the literature now describes it's financial toxicity.
Yes.
Okay. So please, that's why I said I'm just taking it, sort of digressing it. So it is also important to see that what is the real absolute benefit of the next generation TKI and in which setting. So that you have to see that it's not that the first or second generation TKIs are absolutely useless just because something else has been presented in ASCO. So you have to see when you counsel the patient, that is very important that you bring out those aspects. It's very important because as part of holistic care, you don't want to harm the patient's finances so much that although patient doesn't have physical pain, but is very worried. Okay, that is very important. Actually, for brain mets, Anil, you have any questions about the management of brain mets in lung cancer? I'm talking of non-small cell. Small cell lung cancer is the next week. So we will discuss SCLC. Anil, you have any comment or questions for them?
Yes, Tasina, do you know what is the role of TCI in non-small cell lung cancer?
Prophylactic cranial irradiation in non-small cell.
So for advanced cases, so for T3,
So
T4,
or see, first of all, if you don't know, you say sorry, I don't know. Okay. There's a certain thing which you just can't guess and tell. Do you know? Have you read or not?
So I had read.
Okay. Okay. Fair enough.
So, so it was seen in so stage 3 non-small cell lung cancer. So PCI reduces the risk of brain metastasis, but it does not show. So it did not show any survival benefit.
Okay.
Yeah, so RTOG 0214 was a multi-center international phase 3 randomized control trial. The first author was Dr. Alexander Sun. So the trial was closed early because of poor accrual for obvious reasons. So they did show that the incidence of brain metastasis is reduced in non-small cell lung cancer, especially in high-risk population like non-smoker adenocarcinoma histology and age. However, it does not show any improvement in the overall survival. Hence, we do not recommend currently the role of PCI. However, if you see the recent trial by Dr. Arieta et al. From Mexico, so which was presented in last year ASCO, they showed that EGFR or mutated patient and with a carcinoembryonic antigen level more than 20 picogram per ml, if you give PCI, so versus no PCI. So there is an upcoming investigator studies that will be investigating the role of PCI in this particular group of people. So you need to know that. And it actually improved the overall survival also, but it was a phase 2 randomized control trial and phase 3 studies are still awaited.
Okay, sir.
Yeah, but I think Anil, whatever she has said is too good for her standard. It's very good actually.
Is that Tanvir?
I have no doubt on that. Yes, sir.
Yes, sir. Yes, sir.
Yeah. Good. So you
So
asked
I'm
them
really
any
impressed
questions?
with at least that she has said that it can reduce the incidence, but no difference.
Yeah, that's true.
No, I said the
No, sir,
And
actually, I can just ask very basic questions in the exam, like when you and Srivastava sir, I mean, when you were there. So what is the role of steroids? I'll ask a very basic question in brain meds, and when do you start?
Yeah, please
Very
answer.
So I can't hear you, sir. Hello.
He's asking what is
Yes,
the role of steroids and when do you start in brain meds?
Okay, sir. So steroids are used as medical decompression therapy. So we use it when there is associated edema with the brain lesion or when the patient is symptomatic. So it can be either offered in the form of intravenous steroid, or we can give oral dexamethasone with PPIs and other antacid prophylaxis.
Okay. And what are the side effects of steroids?
Good.
Someone has been on
Anything to
steroid
add,
for
Anil?
1 month.
So with steroids, the patient can develop immediately. So the patient can develop gastritis, or the patient can develop steroid dependence. So that is why we have to gradually taper the doses and not stop it abruptly. So there are also chances of increased infection with steroids.
Hello. Yeah, we're listening. So you showed that trial with the overall the quali gain was only of 4.7 days. Is that correct?
Yes.
So is that does that make you very happy? Difference between mean quali or quality adjusted life years, that was in days.
Yes.
In the Quads randomized trial.
Yes, sir. Quads.
Okay. And this was a non-inferiority. So that means
Yes,
when you
sir.
say non-inferiority, so the hypothesis was, just go back, show the title of the, go back. What was the title of the, one slide back, please?
Yes, sir.
So dexamethasone and supportive care with or without whole brain radiotherapy in treating patients with NSCLC with brain mets unsuitable for resection or SRT quads. Results from phase 3. So now again you have to know, so this is a large trial, 538. You should always know which is the year when they recruited the patient, because lung cancer management has, improved by leaps and bounds in the last 10-15 years. So, suppose if they had recruited patients, okay, so March 2007 to, okay, so they have recruited, so you have mentioned the recruitment period. So why it is important? Suppose the study was of 1994 to 97, then what was the difference?
So the systemic chemotherapy then was different. So we did not have the TKIs that we use now.
So chemotherapy was same, platinum and, the other agents. But many of the TKIs were not there. They were just about sort of coming. So that is there. So this is more of a contemporary this thing. And for whole brain RT, things have not changed.
Yes.
And what was the dose of steroids they gave in this? Have you read? No?
So I had read, so I don't remember.
You do not recall. Okay, fair enough. So this was a non-inferiority randomized trial. So go back next. So what is the median survival? So see the kind of patients you have. So the patients are basically quite extensive brain mets because they are not suitable for surgery or SRS. So both the brain intracranial and extracranial disease must be such. What is the median survival you expect in these patients?
So median survival will be so around, so I think 1 to 1.5 years.
1.5 years, irrespective of everything else. So patients with all NSCLC patients with brain mets, the median survival is 1 to 1.5 year, or a subgroup of NSCLC brain mets patient have a median survival of say 1 to 1.5 year.
So it will be subgroups of which will do better.
So in this study, see when you see that, no? So when you see their primary outcome was improvement of at least 7 QALYs. Okay.
Yes.
So if suppose their median survival was expected to be 18 months,
yes, sir.
I mean, no one would bother. I mean, what is 7 days, mean in that?
Yes, sir.
Isn't it? So that is, so what was the median survival obtained in this? So this is a, you do not know. Okay.
Some median survival, no, sir.
No. So, but you guess, your guess is that it will be around 1.5 year for this.
So not this group, sir. So because
yeah, we are talking of this group of patients. That's why I'm saying. So the trial, so you have to understand what was the trial population, because based on the trial population, the benefit that you expect, which will be considered meaningful, is decided. Otherwise you don't consider it meaningful. So all those things are important. Okay. So fortunately, no one used to get mucormycosis earlier. Okay. But anyway, forget about. So what are the other common side effects which you did not mention? Cushingoid features, we only look at it. So proximal myopathy due to steroids, it's very often not appreciated. Patients do not know they have the symptoms because of steroids.
yes,
And we do not know, and it is quite debilitating. And the first sign of proximal myopathy, normally it happens after someone has taken it for 6 weeks or 8 weeks, is when they are getting up from the chair or from squatting position, then they find it difficult, and increasingly they have weakness in the hip muscles, and that could be quite debilitating. And once they sort of become more and more sort of bed bound or chair bound, the bone loss and the muscle loss happens. So I think that is something which you should prevent, and there is no real treatment for that. So that you keep in mind. Okay. And oral thrush also, a lot of times you would see patients while they certainly are unable to eat because they have developed oral thrush while on steroid. They may not be diabetic. In many patients will become diabetic while they are on steroids. So keep all these things in mind. It is not just mucormycosis, which I don't recall seeing any patient with mucormycosis, but there are a lot of side effects which do happen with steroids. It is one of the most misused drug. If someone is not benefiting from it, stop it. And there's no point just giving just because it's a brain met, so steroids have to be given. A patient has to derive benefit out of it to be continued on this thing. So I think anyone else has any comment or question can ask, then we will close this meeting. No? Okay. So thank you very much. You all did a good job. Okay.
Thank you, sir. Thank you, sir.
Okay. Bye-bye. Bye. Bye.
Bye, sir.
Bye. Bye.